just want to orientate some of you out there because this will probably be the first time that you're seeing me and meeting me. Although Dr. Khan sort of introduced me last week. But just to orientate you, this program was started in 2007 under Dr. Bmobile, General Surgeon, on this family station. The goal of this program was initially to sort of impart medical information and useful information to you and your families at home, with the goal that you would incorporate this information to make your right choices for your health. In 2010, the torch of this program was passed on to, as you well know, Dr. Claude Khan, who has manned the floors of this station for the past 10 years and has admirably delivered care to a wide community of patients, especially in the field of diabetes. Dr. Khan has been called away to be with his family at this time, and he has graciously passed on the torch of this program to myself, Dr. Roopnarine, community general practitioner, to carry on and serve you. Before we continue on any further, I think it would be remiss of me not to first acknowledge that since I came onto this program last week, where Dr. Khan graciously hosted me and subsequently introduced me here to take over as host, and this being my first episode as host, I would like to say a very big thank you, first of all, to everyone who has assisted me, to Dr. Khan, and to you, the community at home and in around San Fernando and the greater part of Trinidad and Tobago, and also to my patients in my clinic. You all have given me a lot of encouragement and have a lot of support to continue on tonight. So, just moving forward, tonight's program is going to be really interesting and exciting. I have a special guest with me. His name is Dr. Declan Mahabir, and I will introduce him in a little while. Dr. Mahabir is an ophthalmologist. That means that he specializes in illnesses of the eyes, and he also does eye surgery. So he'll give us a bit more information later on. In the second segment of our program, after the first break, we'll move directly into your questions, and we'll be able to take a live call-in. And the call-in number, folks, is 237-3202. And we'll also be taking your WhatsApp messages. I know nowadays the medium of choice is WhatsApp over the last 2 or 3 years. And our WhatsApp number is 393-ACTN. So thank you very much. And I would like to introduce Dr. Declan Mahabir. Dr. Declan, welcome to our show.
Well, thanks for having me, Robin. That's exciting to be here.
Yes, we're glad to have you. Declan is an ophthalmologist he's based out of Long Circular Mall in a clinic there. He also works with the University of the West Indies as a senior lecturer. So, Dr. Declan, just tell us a little bit about yourself. I know you're a bit anxious. I'm probably more anxious than you'd be my first time here on the show tonight.
Absolutely.
But please just give us a little introduction into your studies, your postgraduate qualifications.
Yeah, excellent. Well, thanks, Robin. So I started in the Royal College of Surgeons in Ireland in '97, as you well know. Graduated in 2002, entered the ophthalmology training program, which I graduated in 2007. Did a lot of retina and glaucoma and cataract surgery at that point. Returned to Trinidad. Had a lot of fun, actually. Coming back, I joined my dad, who is also an ophthalmologist, and I followed in his footsteps as much as possible over the last 14 years of being back. And yeah, what can I say? We're here on ACTN now, you know. I guess my experiences in Trinidad. So started in Sangre Grande in 2009, left in October 2012, and then I got an opportunity to be consultant in Eric Williams Medical Sciences Complex, right. Or Mount Hope.
Right.
Again, there was a further opportunity about 9 months in to lecture to the undergrads predominantly. So joined UE for about a year. Really enjoyed it. I thought it was a lot of fun. It was fun dealing with the bright-eyed, bushy-tailed medical students, you know, just really took to it. Really thought, okay, I could do this, you know. Then officially joined UE really maybe in about 2016, and I've been with them since. Hopefully, I've been making a difference. Trying to develop. It's a continuous process in UE to to develop the undergrad and postgraduate programs. And I think it's making a difference. I think it's really coming together now with the help of Dr. Murray and Dr. Simangaldas, who also lecture with me. They've been we're working really well as a team, and I think it's showing in the results. So as you know, medicine is a continuous process of continuing medical education, where staying up to date is really important, and conferences and lectures and research papers are really what we go to kind of keep up to date, and then we try to transfer that then into the training program. And on top of training people who are coming into the specialty, I think I'd like to hope that we are making a difference and keeping our colleagues and fellow professionals up to date as much as they keep us up to date with what they're doing as well. So.
Right. So it sounds like you have a very busy academic career.
Oh my God, this is crazy. I am so busy. Yes, really, really busy. Yes.
Very good. So, Declan, we have a lot of like medical students and young people at home with their families who might be interested in a career in medicine, more specifically in ophthalmology. For the benefit of our audience at home, our guests at home, could you just give us a little idea of why you had such a passion for ophthalmology out of all the breadth of medicine and different aspects of the field? Why did you choose ophthalmology, and what gets you up out of bed every morning to do this with such passion?
Oh, wow. Hefty questions. I thought it was a nice, neat specialty. It's kind of all-inclusive, but it had arms in other specialties as well. We'll do a little bit of endocrinology. We'll do a little bit of general medicine. Rheumatology comes into it. Neurology comes into it. Peds comes into it. So it kind of is a neat specialty, but it still touches base with a lot of other specialties, which I really enjoy. And as much as possible, I try to practice comprehensively. That for me is the joy in ophthalmology. I think if I got caught up just doing one subspecialty in ophthalmology, that just wouldn't be me. I like the broad practicing across the specialty, and it encompasses medicine, it encompasses surgery, and really, I think hopefully as the show goes on, I'm hoping that we will demonstrate that probably ophthalmology is leading medicine in certain aspects. Like, for instance, in 2014, it really looked like we were kind of getting our first FDA-approved genetic treatment. I thought it was going to take another 10, 15 years, to be honest. And there you go. In September of 2017, it was finally FDA-approved. And we are actually the first specialty to successfully treat genetic disorders of the eye.
Wow.
It's really amazing. Wow. And I think we're leading the way on that. And hopefully it'll spread to the other specialties, and we're going to see genetic diseases. I mean, certainly one area of disease.
When you say genetic diseases, what type of diseases do you mean by that?
Well, the first FDA-approved one, and probably the most successful one up to date, is Leber's congenital amaurosis. And exactly. I was like, what? Can
you break that down a little bit for our viewers?
It is the most common genetic eye disease, and it leads to blindness. And we're just short of one gene, one enzyme, and they were able to. It was pretty neat. In genetic disorders, there's sometimes multiple loci for the disease, but this was pretty neat, and it was limited to one area, and they were able to basically use a virus, the AAV2 virus, to be the vector to actually incorporate the enzyme into the genome of the eye, which is the retina.
Very good.
And they were able to see, and it's really been amazing.
Very good. So that sounds absolutely amazing.
I know,
I understand that's why you'll be passionate about it, because it's very cutting edge
it's not like
improvements.
But the specialty has really broken, I think, the boundaries there. So.
Right. So, Declan, I just want to bring it back to more my specialty,
earthly,
which is general practice.
Sure.
Right.
Yeah.
So, a large amount of the patients that are coming to me in general practice, right, would the necessity for them to go to the ophthalmologist would really be based mostly out of diabetic conditions. For example, a patient will come into me where his sugars might be high or he might be a current diabetic, and you and I both know, and everyone else out there knows after listening to this program for so many years, that diabetes is a multi-systemic illness. So initially, as soon as I get this patient coming in with high sugars, they immediately begin to think, all right, let me check all the different organs, all his different parts. Let me check his eyes, his heart, his kidney.
Yes.
So one of the movements that we have coming out of general practice is that sometimes we would send our patients to you, the ophthalmologist, right? Can you just take me through a little bit of what happens when my patients arrive to your door as the ophthalmologist with a referral letter saying, "There, Dr. Declan, please assist us. This gentleman has diabetes. We are screening for diabetic eye disease." What happens when this patient reaches your door?
Sure. Okay, yeah, absolutely. We go, oh my God, another one? I mean, talking about diabetes in Trinidad is really important. I think that if you look at the top 3 causes of visual impairment around the globe, really, but in third world countries, it's going to be cataract, diabetes, and glaucoma for sure, excluding refractive errors, which is the need for glasses and that kind of stuff.
Sorry, the top 3 causes of blindness worldwide is?
We're going to be cataracts,
yes,
diabetes, and glaucoma.
Okay.
Okay, and then it would vary according to age. There's a little bit of variability. Certainly in the plus 70, plus 80, glaucoma would be number 1. And certainly maybe if you look at 20-year-olds, you're probably looking at injuries really, as being the main cause. So the causes vary according to age, and I think that's the most important thing to bear in mind. But if you're talking about 40, 50, 60-year-olds, it's going to be those 3. So diabetes, as I just spent the whole afternoon lecturing away to the medical students. And one thing that we're really pushing is that Trinidad really has a problem with diabetes. We know that in developing countries, diabetes really is going to be a disease of the 45 to 65-year-old category. But when you look at developed countries like Norway, England, Sweden, their diabetes really develops in the over 65 category, and that's pretty important because you're going to have so many, if you develop it younger, you're going to have so many more years with the diabetes, and we know the duration of diabetes is very important in terms of developing this multi-organ problems that you were talking about, right? So also what's complicating it is that if you look at the white population, they probably have a 2% incidence of glaucoma really within their population. If you go to India, it's going to be 4 to 6 times higher. So you're looking at anywhere between 8 and 12% of your population have diabetes, and that's phenomenal. As you were saying, or maybe you didn't quite say it, but I'm going to say it for you. They have a lot of heart problems, strokes, leg ulcers, amputations as a result of that, poor circulation. They're going to have kidney failure. They're going to have eye failure. And if you look at dialysis, if I have my figures correct, I think it costs the government about $1,200 a session to do dialysis on a patient, and you may need 3 to 4 sessions a week. And then if you're looking at the incidence of diabetes within our population is about 13%. Then and it's going to be about 170,000 people, of which 10% are the bottom 10%, that's 17,000, are going to be really in a lot of trouble with vision and kidneys and
so I just want to focus you back hearts. Again, Declan, in the discussion, more for the benefit of all of us.
So what do you do? So
what do you do?
Well, there you go.
What do you look for?
Thank you for that. I tend to go off the point a little bit. So what do we do? I think what we try to do is we try to assess where they're at and where we want them to. We want everybody to have 20/20 vision, and how are we going going to get them there. So, diabetes leads to a number of other problems. If you have diabetes, you're twice as likely to have glaucoma, open-angle glaucoma. You can actually develop a type of angle closure glaucoma. Cataracts, you're twice as likely to have cataracts as premature cataracts with diabetes. But really, a lot of times you get a lot of swaying in vision. So with people who have sways in their blood sugars, their refractive error, so their glasses will be a little bit of an issue. So we assess all of that. We check their vision, see if glasses make it any better. Then we look really at the anterior segment. We test their pressures to see if they have glaucoma. We look at the state of the cataract, and then the retinopathy, which 75% of people have at 10 years of having diabetes. You tend to see a lot of retinopathy as well. So hemorrhages, microaneurysms, leakage. There's common things that we see. But then when you get overt bleeds in the eye and neovascularization, which lead to the bleeds, then we know that things are very serious, and we up the ante. We actually have to do a lot of therapy, which involves lasers, which are amazing for diabetic eye disease, and injections as well.
Declan, so we just want to leave that point there, and we'll get back to it.
Yes, no problem.
We just want to take a quick commercial break.
Please,
so we'll be back in 1 minute. Thank you very much.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, so welcome back, everyone. Again, we have Dr. Declan Mahabir, consultant ophthalmologist, here with us tonight. This is Your Health, Your Choice. My name is Dr. Roopnarine, general practice. And Declan, I'm going to go straight into a question that we have here on WhatsApp.
Fantastic. I can't wait.
So the question is, I recently had an eye examination. I was told that both my eyes have cataracts. I was also assured that they are both very small and pose no threat to my vision at the moment. Any advice moving forward? I am a 55-year-old female. So Declan, how would you, this is a 55-year-old lady. She went to see her eye doctor. She was told that she had cataracts in both eyes and that they were small, posed no threat, and that she could go ahead. You could answer the question first, but you could also just give us a little insight into cataracts and the treatment for cataracts and how we would move forward with that.
Sure, absolutely. Great question. I think it's something that a lot of people come across pretty regularly. And so it's a little difficult to advise you because I don't have all the details that I need to really give you some rock solid advice. But what I would say is that if your vision is excellent, there's no need to move ahead with surgery. I think what it sounds like is that he's giving you a little heads up that maybe in the next 5 to 8 years or so, you'll probably need to have some intervention. In terms of cataract surgery, if I had to pick an age that stands out as the age that a lot of people need to have surgery, it's really early 60s. I mean, I'd say 62, 63 by far. And I think if there's been anything that I can say about cataract surgery over the last 20 years is that, we're doing it a little bit earlier for patients. If you go back 30 years ago, a lot of patients would have been told, hey, your cataract's not ripe enough, it's not ripe enough, we're going to leave it, And that's because with the techniques that we had 30 years ago, our hard lens made it a lot easier to do the surgery and patients did really well. Okay?
Sorry, what was that, your hard lens?
A harder, more mature cataract made the surgery a little bit easier. And people really reap the benefits of the surgery without the complications and that kind of stuff, okay?
Right.
So, but we've moved to small incision surgeries. We've moved to phacoemulsification, and really
Moved to what, sorry?
phacoemulsification. So
What
that
is
is
that?
where we melt the lens in your eyes. Yeah.
Very good.
And there's a technique that we use for melting the lens, and we do it through a very small incision. I think patients do better when they do it earlier, and I think I think the ophthalmologists are just prepping patients to understand that as well.
So basically, to answer this lady, you're saying that it's a small cataract. It's not affecting her vision, and therefore there's no necessity to take further action.
Well, I think there are things that you can do. You can update your glasses, because we know that when you're developing cataracts, you get shifts within your refraction a lot more commonly. So rather than getting 2 or 3 years out of your glasses, you're going to find that maybe after 18 months or a year, it needs to be changed again. And that's really a sign that it's probably coming on and you'll need to do the surgery. Cataracts cause a thickening of the lens, and that makes it a lot, makes people short-sighted, makes the lenses stronger, and that can be overcome with glasses. On top of that, I mean, there's been a lot of, I think, relatively good evidence that if patients eat well and take care of themselves, diet and exercise, their cataracts, their cataracts don't progress as quickly. So,
Right. So I think we have a call on the line. Josh, it's on us. We have a call on the line. Go ahead.
Hello?
Hello.
Yes?
Hello.
Yeah, hi, Robin. Dr. Claude Khan here.
Hi, Claude. How are you?
I'm okay. I thought I would ring
You're
in.
checking in on us?
Congratulate you guys. After having done the program for over 10 years, I'm sure a lot of people are viewing. So, Robin, first of all, I want to congratulate you on taking the torch, the baton.
Thank you, Claude.
Declan, I've never met you personally, but you have seen a lot of my patients over the years. So I want to thank you for your excellent service to my patients. But I do have a question.
It was a double-loaded hello.
yes. This is probably my last opportunity to ringing.
Feel free.
Diabetic retinopathy is a major problem in our diabetic patients, and unfortunately, we are seeing patients at a very late stage because the typical phrase that patients use is, "Doc, I'm seeing okay. Why should I go and see an eye doctor?" So there are two things. We have the optometrist and ophthalmologist. So patients would often ask, should I go and see an optometrist or an ophthalmologist? That's the first question. But the second thing I just want you to comment on is retinal screening. Getting patients to understand that they should not wait until they have a problem with their eyes. But we are now in the Southwest we were doing retinal screening. So just two questions, optometrists versus ophthalmologists. And the second question, just a few comments on how necessary it is for a retinal screening program in Trinidad. Thank you very much, guys.
No problem, Claude. Take care.
Well, thanks for a very good question. I've got to say, well, let me start off by saying, I have to say, I found that Dr. Khan is probably one of the best out there. I mean, I oftentimes get a lot of difficulty getting other doctors to understand, about blood pressure control and AIMS and HbA1cs and that sort of stuff. And he has been on the money all the way through. Fantastic, and certainly made my job a lot easier. But he's asked me two pretty difficult questions. They're tricky. They're tricky. Retinal screening in every other country is something that is a hallmark of their healthcare system. Yes, I agree the Trinidadian patients are a little bit relaxed about that, and it does make things very difficult. It used to be that when I first came back, patients would not have heard about doing eye exams. And I think over the last 14, 15 years, that through the good work that we've had with Dr. Khan and the other GPs and diabetologists and physicians and endocrinologists, that the word's out there that you do need to have an eye exam. And I think that patients are find it difficult when they're seeing well to understand. But we have a couple of videos that maybe we could help to prime our population to understand why it is that these things are pretty important. You can get a lot of diabetic changes and actually have really good vision, 20/20, better than 20/20 vision. But they are warning signs to us that you're about to have a major incident, a major bleed in the eyes. And really, I think if I was to talk to doctors across Trinidad and Tobago, across the planet, most doctors would agree if we can prevent a problem, it's cheaper, easier, better, and faster.
Preventative medicine.
And you get better results, exactly, if we can prevent vision loss. And that is really the aim of diabetic screening, that we identify early disease when it's treatable. Patients are going to do so much better. Like if we have to do laser, you're talking maybe about $3,000 to $6,000 for laser, for instance. If you have to do a vitrectomy, you've got to fork out about $40,000. It's a 2-hour surgery with multiple risks, and we're not sure that actually patients would improve once the surgery is done. Whereas with laser, if done in time, everybody's going to keep 20/20 vision. Ophthalmologists versus optometrists. So it varies from country to country, and I think that's important to understand. What optometrists do in England is not what optometrists do here in Trinidad. The training in England is slightly different from the training here. The training in the United States is vastly different from the training that is done, for instance, in England. So it's up to every country to decide really where the burden really lies. But I would say an optometrist, really the strength of the optometrist really lies in somebody who doesn't have any systemic diseases or high risk factors for going blind. Meaning if you were relatively okay and you just needed glasses, then I think visiting an optometrist is excellent, okay? I think if you have a dedicated disease and there's a risk that you could go blind, I think really the ophthalmologist is the better bet, okay? I know there's a price difference, but there's definitely a training difference as well. An optometrist in this country trains in the university for 3 years in theory, 1 year in practice, and then they're allowed out, okay? They do 3 months in the eye clinic and they see what we do and they're kind of involved with what we do as ophthalmologists, and they're trained, and there is a bit of screening that I agree that they would be able to do, but again, that is based on ongoing training and that sort of stuff. The ophthalmologist has to go to medical school for 5 years. They've got to do internship for a year. They probably house officer for quite some time. Really, most people get their exams after about 6 to 12 years. So you're really looking at training from the time they enter medical school to the time they're fully practicing on their own. Probably about 12 to 16 years, depending on where you're being trained. And so bottom line is,
Let me just, before we go to the next break, Josh, you could just pull up can you pull up the video that Dr. Declan had there on the cataract surgery?
Cataract? Okay. So so I think you saw the schematic, little cartoon version of it a few minutes ago while I was talking. And here you're actually seeing live surgery, live recorded surgery of what we call phacoemulsification. So he's using a diamond knife to make his incisions. He basically tears the anterior capsule of the lens, and that gives him access to the actual lens itself. In the center of the lens, you can see this very sclerotic cataract. So there's no doubt that this needs to be done for sure. So he's doing a lovely job here. And he's going to loosen things up by injecting a bit of fluid around so it makes the lens more mobile.
We have a call on the line, Josh? All right. Can we hold the video, Josh, and we take the call? Hi, we have a call on the line. Good evening. You would like to speak to Dr. Declan?
Yeah, hello, doctor. Good night.
Good night.
Yeah, I have a question, but it's not pertaining to the cataract. I don't want it to be off course, but it's a doctor question. My blood pressure, I'm a high blood pressure patient, and sometimes the lower one, the one that underlined that's supposed to be about 90, sometimes it is dropped to 60, even 55.
Right.
And want to know if that could be a problem, if that is to worry about.
Can you repeat what your blood pressure is?
Yeah?
Can you repeat your blood pressure reading, please?
Yeah, I take my blood pressure reading often.
Right. And what is the reading?
Sometimes it'll be 120 over 60. Sometimes it is 125 over as low as 55. I want to know if that low one is that something to worry about.
All right. We'll answer the question for you, sir. Declan.
Sure, yeah. I think you're going to live a long time with a blood pressure like that. That's amazing. I wish my blood pressure was like that. That's excellent. I think you're, as long as you're feeling well, some people, if their blood pressure goes a bit too low, they get a little lightheaded, especially from sitting to standing or lying to standing. If that is the case, then I think your dose could be tweaked a little bit. But that should be done by your doctor, under the supervision of your doctor. So usually if you give them a little buzz on the phone, I think that could be handled over the phone.
Yeah.
I would say the best way to know what your blood pressure really is like is to do a 24-hour blood pressure monitor. So that is something that can be done, I think, through most institutions have it. It's a little device you wear. You hold it you put it on for 24 hours, and every 50 minutes it'll take a blood pressure reading, and then when you give it back to the doctor or the institution that you got it from, they'll give you a reading of what your blood pressure is throughout the day.
Right. So I hope that answers your. Okay, we have another call coming through, Declan.
Okay. Yeah.
All right. So, good evening, caller.
Good evening, Doc.
Good evening.
Doc, I had a cataract operation, right?
Yeah.
To remove cataract. But what I discovered after a little while, like maybe about 6 months after, I noticed that the eye that I got the cataract operation on, it's showing more white than the other eye, in the sense that, like, if I'm looking at the fridge, right, the normal eye look kind of cream, which I want to believe that is the normal color, right? And why this light, this eye that is showing more white? When I say like the object, it is a white object. Well, you know.
Okay, so you good with that, Declan?
Yeah, that's
So if you just hang up there, Dr. Declan will answer your question.
Fantastic. Thanks for bringing that up. So I guess this is the whole trick with cataracts. Sometimes it comes on so slowly or so insidiously that you don't notice that you're getting a change in your contrasting, that reds aren't as red, blues in particular aren't as blue, and whites aren't as white. And so what happens is that I think he's seeing so well in the eye with the cataract, he's getting true colors, and I think he's starting to notice that he's not seeing as clearly in the other eye. So that's what I would say is going on with him. Also, I just want to bear in mind, I was just looking this up because I do a lot of postgrad stuff, and we have to get questions and stuff, and I was reading through the chapters, and really, I want to say that a lot of people after cataract surgery really see amazingly clearly. But really what's happening is the lenses are allowing more wavelengths through. So you're actually getting more light and more stimulus to the eye than ever before. So they have filters on the lenses that actually block like a lot of UV and things like that. Your own natural lens is a natural UV blocker. So that is, that is imitated in the lenses that we insert. But yeah, I think we get much more light in and more wavelengths in, so your contrast of colors is much better as well. So one of the advantages of having it done.
Okay, great. That's interesting.
Yeah, it is. It's really actually. So just read that today.
Josh, if you could go back to the video for our viewers, please.
Yeah.
On the cataract surgery.
Let's try and finish this video. It's quite a lot to take in. So he's loosening the lens, and he's going to be able to. You're going to see him rotating it later on, and this is the prelude to that. I wouldn't say he's the gentlest surgeon now, but so here we go. Yeah. So he does a stop and chop technique. So you're going to see him just doing a little cleanup there. He goes in and then he cracks it into two. Nice, very smooth. And so he's got two pieces and he starts taking them in individual pieces. Some people do it in 4 pieces, but as he narrates, he'll pretty much tell you, it was willing to come, so he just took it. So really, this is the substance of the cataract. And then what we do is we just clean things up. This is the epinucleus that he's removing. And as soon as he does that, those little feathery bits are just going to be aspirated with an INA. Yeah, there you go. So he's going to clean that up. And once he gets it all cleaned up, he's going to insert a lens. And that pretty much is the surgery right there. So he's cleaned everything up. He's injecting a bit of gel to keep the eye inflated. And here you go. Lovely, beautiful lens right in there, and he puts the new lens where the old lens is, okay? And, the technology in the last 20, 25 years has meant that we have lenses that are 13 millimeters going through a 2 millimeter incision. And that was a trick there. So we can do everything, no blood, no stitches, nothing. This is a self-sealing wound, which means that there's no leakage really from the eye, which is what he's checking right now, and that's the surgery right there.
Wow.
Yeah. So really nice and neat. And we say it's like 15 minutes, maybe 25, 30 minutes. I have a lot of medical students around, and sometimes I, just break the monotony of the day. We do little
Right.
bets,
Right.
So I was.
I haven't Josh there that's ringing in my head, so it's time to take a break.
Okay, no problem.
So we'll take a short break now. It'll be about 1 minute. As I say, call in. Dr. Declan is here. You can ask me questions on ophthalmology, any kind of diseases of the eye, any queries or questions that we may have. Call in. So we'll be back in 1 minute.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
At the moment, we have a question coming in on WhatsApp. It's my 37-year-old daughter with no known health issues has pus inflammation coming out of the corner of her eye each morning. Please, could you advise?
Yeah, okay, well, a pretty common problem. So
Right.
another really good question, Robin. I think your guests are doing a great job of asking questions. So it sounds like, although, it's kind of hard, over a TV interview to really sort of nail this or to get it right with 100% accuracy. But
With the information you have,
yeah,
we can
I'm
kind
gonna
of
say-
help out with the information you have.
I'm going to say like 90-95% sure that this is MGD blepharitis, and very common. And I know, it was a mouthful. Blepharitis.
Blepharitis.
Yeah, blepharitis. We'll go with that, right? And that's pretty common. And so I'm just going to do a little analogy because I think it's easier for people to understand oral hygiene better than eye hygiene. So oral hygiene, everybody out there knows that they've got to brush their teeth 2 or 3 times a day to keep the bacterial level down. So you have a high bacterial count in the mouth. It gives you halitosis, bad breath, cavities, plaques, yellowing of your teeth. I mean, you name it. I mean, people out there are really well informed about oral hygiene. But you can get from the glands around the eyes, a high bacterial count in your eyes. And it's not an infection, just like when you brush your teeth, not because you have an infection, but because you have a high bacterial count. So there is a little a technique that we offer people to do, and it's very effective, although it sounds a bit strange for anybody who's hearing it for the first time. So I usually ask people to get 2 cups of warm water, 2 squirts of baby shampoo, and then 2 drops of tea tree oil into a solution. Okay?
Declan, I just want to put you on hold there. We have a caller coming in on the line. Caller?
Good evening.
Good evening.
I went to see an eye specialist because the one doctor told me I had glaucoma, not glaucoma, cataracts.
Yes, ma'am.
And then when I went back, he said I did not have any cataracts.
Okay.
I knew why he did that, but listen. So then I went to see this eye specialist. He told me that I have cataracts, but they are small. He gave me an eye drop, but my eyes are paining me. I'm getting a lot of pain in both eyes. And he said the cataracts are small. They cannot cut it now. So what do I do?
Right. Well, Declan?
Sure, absolutely.
Our lady is calling in. She said she saw one ophthalmologist. He said she something about they had a cataract before, then there wasn't a cataract, and then she went on, but to say that her vision is fine, but she's getting a lot of pain in the eyes. And she wants to know what to do. So basically, sounds like she needs some help.
I wouldn't want to say that this is the platform in which we can solve that problem for you.
No.
Right? I think I'm not sure that the doctors were aware that you were in eye pain at the time of seeing. I'd just maybe, if I would have clarified that a little bit. Also, so I think maybe getting a third opinion in this case might be warranted. Pain is usually not something that we tolerate, I think, as physicians. We don't allow people to be in pain if we can avoid it, you know. I do want to say, though, was talking about MGD and blepharitis, and that, again, is pretty common, and it does lead to a little soreness and burning in the eyes. And so it is well worth going ahead and doing your 2 cups of warm water, 2 squirts baby shampoo, 2 drops of tea tree oil, getting a nice soft cloth, and what we ask you to do is to clean and rub the eyelashes right on the base of the eyelashes, and it reduces down the amount of bacteria that's in there, the burning, the stinging, the intolerance of bright lights, that kind of stuff. Very common. I would suggest maybe doing that, but give that a week or 2, 15 minutes a day for 2 weeks, and then if it's not working, I think you do need to see someone about it, yeah. So.
All right, so we have another question coming in on WhatsApp. Is it effective if I'm using Xalatan drops and the drops goes down to the back of the throat?
Yeah, absolutely. So I guess this is not very well explained in most offices, but we actually have a natural passage from the nose, from the corner of the eye into the back of the nose called the nasolacrimal duct. And it's the reason why when we cry, we get a runny nose, because the tears actually start draining down and they cause a runny nose. And so it's normal for eye drops to actually pass down into the back of the nose and into the back of the throat. And it has a terrible sort of bitter taste that a lot of people seem to really object to. So you may be putting too many eye drops in. One, your eye can probably hold an eye drop, maybe an eye drop and a half. So if you're getting 2 eye drops in, the excess is going to spill down into the back of the throat. One really good way of actually stopping that from happening is when you put the eye drops in, just put a little pressure right at the nasolacrimal sac, and that will prevent the drops from draining down into the back of the throat. So you can keep the eyes closed, put a little pressure on both sides, and I can assure you that the bitter taste will go away. Also, I just saw a message from someone saying that they have flashing lights. I thought I didn't want that to really go by unaddressed. Flashing lights can be quite dangerous, and so if somebody's got lights or flashing lights in their eyes, they do need to visit the ophthalmologist. There are a couple things that we consider in flashing lights. So flashing lights is usually Harrell's PVD, posterior vitreous detachments, and most people will go through a PVD by the age of 65. So the percentage is 80 to 85% of people by the time that they're 65 would have gone through a PVD. But a PVD can actually lead to a retinal tear and a retinal detachment if that occurs. So it's a minority of people, but they do need an eye exam to make sure that that is not the case. So that is an ophthalmologist, and it needs to be done within about a week of you getting the flashing lights.
So we don't have the name of the person that actually sent in that.
Yeah, I think it's there, but we'll look for it at the end.
Yeah, and I think we'll probably touch base with you after this program as well.
Also to mention, there's a couple other reasons why somebody may get flashing lights. Migraines.
So they're coming fast and quick now.
Oh, wow. Migraines and ocular scheme.
So we have a phone call. Good afternoon, good evening, caller. Hello? Hello.
Hello, good night.
Hi, good night, ma'am.
Yes, lovely topic.
Thank you, ma'am.
I just want to find out something. I have a bit of blurriness in my eyes, but sometimes I can't even see my own food. But I've been checking it, and there's no cataract, no glaucoma, nothing that's really, and sometimes I see the same color, but not as much. I can't really say that I do see that flashing color, but I'm not sure if it's because I recently or about a year or two had like chemo and radiation, especially the radiation. I don't know if that is causing the problem, or, that it is. But it's really uncomfortable. I feel very uncomfortable with this blurriness constantly.
Okay. Declan, do you want to call it to hold your line, or she can hang up? Do you want to ask any more questions to her?
No, it's okay. I think we can tackle that. Yeah.
Okay, ma'am, you can hang up the phone, and Dr. Declan will give you his response.
Yeah. So I think blurred vision, especially if you've had radiation in the head and neck area, I thought I heard her say that.
Yes.
That needs that's an important eye exam to also get. You can get a radiation retinopathy as well. But it could be a simple, a lot of stress, chemotherapy, that can affect your accommodation as well, which is what it kind of sounds like. So I think we need to do an eye exam to make sure that there's nothing else going on. But even if somebody's very stressed, you're going to get that. But you also have to check blood pressure, blood sugars. Changes in those will also account for her symptoms. So she needs a lot of
final word of advice to that patient?
Just get an eye doctor that you're happy with and head down, explain.
And check for chronic diseases as well?
Yeah, we got to check for systemic diseases and eye diseases for you.
So they're coming in fast now. Good night, doctor. I have a question. My 19-year-old son took 2 eye exams and was told he has 2400 vision and no corrective surgery can be done. Can you advise?
Again, that's going to be a little bit difficult.
That is,
I mean, it's a 19-year-old with pretty poor vision there. So 2400 is really the top letter on the chart, on the Snellen chart that people will be familiar with. So it's only
the top one.
It's the top one, yeah.
Wow.
So it sounds like that there is usually in that age group, it's genetic disorder. So they were born with a problem, like
then we have to know whether he's suddenly
it could have been amaurosis.
Because he's 19 years old now.
So we need to figure out what the underlying problem is. And like I said, we're breaking barriers in ophthalmology. And to me, it's hard for me to think that there isn't some sort of genetic syndrome there. And we're getting better at treating those sort of things. So I think it's well worth, again, seeing somebody who's a trusted ophthalmologist and to get their opinion. Okay.
Right, so we have, Josh, you have a voice note there?
Good night. I had surgery on my eyes. I did a retina surgery plus a laser for the bleeding behind my eyes, and they took out the lens. They replaced the lens. My question is, it's finished, it's done. The doctors review it, and he said that it was okay. The retina is fine. My question is, I'm still seeing blurry. How long would it take for me to see clearly?
Yeah, Declan? We have some information.
Sounds like she had a lot of very advanced disease, because when we do vitrectomies for patients, they really have got pretty much end-stage eye disease. So what we're trying to do is bring back end-stage eye disease back to 2020. And the truth is that if it hasn't happened within the first 6 to 12 weeks, the likelihood really is it's very unlikely that it will get better.
All right, so we have a few more questions, and we have about 5 more minutes for the program. I don't know where the time went either. So we're trying to get through it and try and assist everyone, obviously.
Sure, yeah.
Okay, this is a question for Dr. Declan again. I have a black spot and bubbles in my eyes. Where can I get relief from this problem? Thanks.
So that's all part of really being over the age of 55. You tend to get floaters in your vision, and they can look like a mosquito or a cobweb. And it's pretty common. It's part of that PVD process. You can get flashing lights with it. Again, there's nothing I can do except to advise you to see an ophthalmologist about it. Because if you develop a retinal tear, retinal detachment, which can be prevented if you find it very early on, then it's going to be a major problem. You're going to end up in the same boat as our last caller, which is having a vitrectomy and with no chance of really improving your vision. So that is something that we want to avoid doing. So if you've got floaters, bubbles, things in your vision, that really warrants you to go in and see an ophthalmologist. And it's not me. I've done 4 years of vitreoretinal, not in this country, away, and I can just tell you the number of people that I've seen with retinal tears, retinal detachments that we've saved was phenomenally high.
Wow.
So it is something that just needs to be screened out, and it could take a couple of months for you to finish that screening process as well. Sometimes up to a year. So.
Wow. Right, so we have another question. Good night, Dr. Declan. My mom has cataract in both eyes, but one is worse than the other. But now the better eye is seeing flashing green and yellow lights. It started Sunday evening.
So PVD again,
Yeah.
the flashing lights and floaters. And I'll tell you, there's a 2-year risk after cataract surgery for developing a retinal detachment. So, wow, it seems to be a common theme here. Yeah. So very important that she goes back to her ophthalmologist that she did the surgery with and be seen this week. That is important. Very, very important. There could be a retinal tear just sitting there. So.
Right. So, unfortunately, as Josh has told us, we have come to the end of the program.
Already?
Already, it flew by. Loads of questions came in. Obviously, Declan, we're going to have to bring him back another night. We still have about 5 or 6 questions
Only 5 or 6? Oh, no, I'm disappointed.
So, ladies and gentlemen, before we sign off tonight, myself and Declan, we have been good friends for many years. We trained together, and that's why I thought Declan would have been a good guest to bring on into the program tonight. So we wanted to have a little dedication to some of our colleagues. So in closing tonight, Dr. Declan and myself would like to dedicate this episode of Your Health, Your Choice, not only to healthcare staff here in Trinidad and Tobago, but we would also like to transmit our solidarity and homage to our international colleagues and their patients, especially those working in underdeveloped and developing countries around the world. Many of those doctors, myself and Dr. Declan, would know personally. Tonight, many of our colleagues are delivering care in very remote and isolated environments with scarce available medical resources. To them, their loved ones, and their patients, all of us here in the studio at ACTN send our highest hopes that they may overcome the challenges that they face, and that all of your patients have a full return to good health as well. Thank you, everyone. Thank you for your calls. Thank you to Declan for being a wonderful guest.
Thanks, Robin. I had a blast.
I really appreciated it, Declan.
Absolutely. Fantastic. Great show.
Thank you to all our viewers at home. And Josh, you can take us out.